It's a big honor for me to participate in this oral session of AFRA Congress with our cases about solving two problems by simple solution. Traditional RV pacing has been widely used to manage symptomatic bradyarrhythmias, but RV pacing has been shown by several studies to be associated to pacing-induced cardiomyopathy with a prevalence of 15 to 20% of patients who were paced for more than 20%. Thereby, the young age, especially in congenital AV block, which need a permanent dependent pacing, has a significantly poor prognosis with high risk of mediated cardiomyopathy, recurrent heart failure, atrial arrhythmias, and high risk of mortality. That's why this novel therapy targeting physiological pacing was introduced to overcome the side effects. But physiological pacing demonstrates not only the prevention of mediated cardiomyopathy, but also improvement of left ventricular ejection fraction in group with depressed left ejection fraction. And this benefit effect was demonstrated in both adults and children. After his bundle pacing, the transeptal approach was developed. Left bundle pacing area recently emerged as an extremely attractive technique with promising results, overcoming several limitations of his bundle pacing. Targeting large area, consequently offering short course of training with high rates of success implantation, deep implantation with more stability and less risk of lead revision and infection, good and stable parameters, large R-wave, low pacing threshold, avoiding risk of early battery depletion, and the latest advantage is the most important in our category of congenital AV block is the prevention of loss of capture due to the distal progression of conductive system disease. Here we report the case of 27 years old female diagnosed with congenital AV block 5 years ago. She was referred to our department due to dizziness symptoms and recurrent syncope. Physical examinations showed pulse 20 at 27 beats per minute, blood pressure 180, baseline ECG showed complete AV block with ventricular escape and QRS width at 180. Echocardiography showed moderate dilated left ventricle with the ejection fraction of 48%. Laboratory examination was normal. We choose a main picture to show you how we collect our 12 lead. So we start by inserting temporarily transvenous pacemaker as a backup pacing during our procedure. And the fluoroscopy guided the left axillary vein was accessed using caudal incidence. Two separate wires were placed. We advanced the sheath catheter over the tricuspid annulus using RAO 30-degree view and contrast, and we took our reference. We advanced after carefully selected secure lead, and then the whole lead catheter targeted our area under the summit of the tricuspid annulus by about 2 centimeters. The helix gave PVC's lesion with Q notched pattern, PVC in V1, especially in the last PVC, positive lead 2 and the discordance between the R and AVL and the Q and AVR. With firm counterclockwise under LAO 40-degree view and perpendicular position of the lead to the septums, we start screwing the lead. Once we got the right Vandal branch block fixation PVCs, unipolar pacing and impedance were assessed to follow the QRS morphology and the progression of the lead. And this is our final ECG recorded at the end of our procedure. So with high output on our left, we see the RSR pattern in V1, and the time between the spike to the peak of R was 65 milliseconds. With low output, we lost the R in V1, and the time still the same. So the parameters was the time from the spike to the peak of R in V6, 65 milliseconds, QRS duration at 100 millisecond, R-wave 10 millivolts, pacing threshold 1 volt for 0.4 millisecond, impedance 60, 190 ohms, and current of lesion 8 millivolts. But 2 hours after, we were very excited to record the surface ECG, but we see the complete disappearance of our right bundle pattern in V1, with the width of the QRS right now at 120 milliseconds. So we converted to deep septal pacing, but all the parameters were very good and stable with no signs of perforation. We see our patient 2 weeks after. Recording ECG showed the same QRS pattern with duration at 120 milliseconds, R-wave at 12 millivolt, pacing threshold at 0.5 volt for 0.4 millisecond, impedance 660, and we did an echocardiography that showed an ejection fraction slightly improved to 52%. So, left bundle branch area pacing gains rapid acceptance due to its broad targets area and excellent electrical parameters. The implant technique for children and young patients is the same as for adult population, with some challenge as small body size, existence of sponge-like or less compacted system, and that was our case, risk of perforation or dislodgement. So we choose the left bundle area pacing because of the chronic stable pacing threshold. Here we have this recent publication published in August about congenital AV block in children and young patients, and we compare between two groups, Hayes bundle pacing and left bundle pacing area. We see clearly the significant rise in the pacing threshold in the group of Hayes bundle pacing. Second things, we choose the left bundle pacing area because that's protect from the loss of capture due to distal progression of the conduction system disease. The second point was about the septum. The septum is known in younger to be thinner with high risk of perforation. So we choose the luminous electrode that has a smaller diameter and less complication, less traumatic, less risk of perforation, and less risk for collateral damage to septal vessel. But unfortunately, we were faced to another frequent complication that was highlighted in some reported cases, which is the conversion to deep septal patient. In our case, we choose that could be related to the soft septum. To conclude, concern regarding the technical challenges, procedural characteristics, pacing system performance and outcomes in pediatric and young adult patients with congenital heart block are needed. And further development of specific delivery tools is desirable to increase the rate of successful implantation in young population. Thank you for listening.